Welcome to my workplace at Ranaghat, West Bengal, India. Let us discuss this surgery. This surgery is being done by my trainee, and she does some movements in the anterior chamber, and the rhexis runs out. Then she takes a scissor, goes to the other side, makes a cut, and takes a needle, and somehow he completes the rhexis, but there is a weak point at 3 o'clock. Now, how can it be prevented? See this stage. This is the stage where we can prevent it. We must not hold at the body of the tag, we must hold at the edge of the tag. She is holding at the body of the tag and making a pull so that it goes to the periphery. Now, once it has happened, the senior has to take up the case. This cannot be left to the trainee because safety of the patient and vision of the patient is the main goal of our surgery. A little bit of hydrodissection and bimanual rotation. And now, to cause less stress on the geniole and cause less stress on the posterior capsule by the irrigation fluid pressure, I take the nucleus sustainer, which gives support to the equator, and take this nucleus cutter or pre-chopper and cut the nucleus. And it divides into two heminuclei. I come out, rotate it, inject some visco, and again I go with the nucleus cutter and cut this heminucleus into two fragments. Then I rotate 180 degree and inject visco again. The left hand should be rock steady, it should not move if we keep the ball tip chopper in the or sustainer in the anterior chamber. Now the other heminucleus is engaged, and this is also divided into two pieces. So we have divided this grade 3 or grade 3 plus nuclear sclerotic cataract into 4 fragments by a nucleus sustainer and the nucleus cutter or nucleus pre-chopper, whatever you say. And now we have done the main job. We will not apply any irrigation pressure on the posterior capsule, on the anterior. Now I am trying to pull out on fragment out of the bag, but it was not possible. So I asked my assistant to decrease the bottle height, decrease vacuum, cause less irrigation pressure, and go in, and immediately as I go I start vacuum, and I keep the anterior chamber not very deep. I keep it normal, not much of irrigation pressure, and then I pick up the fragments one by one and emulsify the pieces. This is done safely, and this needs some learning curve to do this. But once you learn this technique, I think most of the time you will not require to convert to SICS in such situations. No irrigation pressure on the posterior capsule, not on the geniole, and the case is done. some visco, not much of visco, not to cause a lot of pressure on the posterior capsule, and use the Simcoe to remove the cortex. Simcoe with less bottle height and keeping the AC on the shallower side, not on the deeper side, so that we cause less stress at the weak point. Little visco, not much, this much. Still the posterior capsule is bulging little bit forward. Done. Cortex is clear, and we can safely put the intraocular lens in the bag. The bag, though not intact, the haptics will be under the rexis margin. Whatever anterior capsular rib is remaining, the haptics will be within that anterior capsular remnant. No hydro implantation, just fill up the AC, not too much, normal depth, and implant the lens. These are the tips. So when there is a weak point, when the rexis runs out, decrease bottle height, don't cause any irrigation pressure. If you can pre-chop or pre-cut the nucleus into pieces, it is fine. Decrease the bottle height and inject visco. Go in and immediately start vacuum so that the irrigation pressure is not much. Irrigation and aspiration occurs together. Bottle height may be about 70 centimeter or 60 centimeter, and vacuum also less, about 300 to 400. Ultrasonic energy in grade 3 maybe about 55%, and do a very nice, very cautious job. These are the things that you have to do when you are a senior and supervising a training, and you must learn to manage such situations. If you are not confident to do this, if your gut feeling is telling you to not to go for it, please don't go for it. Please convert to SICS and implant a lens which is overall diameter is about 13 centimeter, like sensor multipiece lens or Oro multipiece lens, which goes in the sulcus. And the rigid lenses, which are about 12.5 millimeter overall diameter, it's not good for such cases. It will decenter. And see the centration of the lens. This is because the haptics are under the anterior capsular remnant. I am sure the patient will do well in the postoperative period. And here we conclude the case. Thank you very much for your patience. Thank you very much for your eagerness to learn surgeries, to learn how to manage complications, be a great surgeon, and serve the mankind with love, respect, empathy, and great surgical competence.